senior professionals and dear friends, SGLT2 inhibitors and DPP4 inhibitors combination, where to place the diabetes management in today's practice. You may be wondered why I have put the BP apparatus here, even though the topic is on the diabetes. That implies that BP recording and the PP management, elevated blood pressure management is very, very important in all the cases of the diabetes, because 75% of the diabetic individuals are the hypertensives. See this picture, in 2019, the people of the diabetes in India are about 7.7 crores. They expected that the number of the diabetes would be 13.4 crores in the year 2045. Okay, that is their expectations in 2019. But today, in 2023, just 2 years ago, it was already 10 crores. By today, I think there are about 13.5 crores of the diabetics are there. That means we reached that figure of 134 millions, supposed to be raised in the seen in the year of 2045, already seen in the year 2025. So this slide implies that the diabetic increase in the number of the diabetics in India is in exponential growth and in a tsunamic proposition. So that is the reason, whatever the specialty we are practicing, whether you are a GP or a specialist or a super specialist, so one should not underestimate the value of the diabetes management for all of us. So that is the reason every doctor in India must learn much about the diabetes, and they are supposed to treat all the diabetic individuals, because 95% of our diabetes can be treated by the general practitioner. Only the 5% will require a specialist care or a super specialist care. So from tomorrow onwards, you all please start doing diabetes practice, and you all should behave like a diabetologist. We all know the management of the diabetes is not that easy, but definitely if you control the glycemic, so definitely you will have a lot of the benefits. Just 1% reduction in your HbA1c will give you nearly 30 to 40% reduction in all your complications, and also your cardiovascular risk reduction, and definitely will have long-term benefits and good quality of the life. Even though we have a lot of the drugs, even though we have so many CMEs in all over the world, but still in India, 70% of the people in India, they do not reach their HbA1c targets. So you know our target of the HbA1c in young individuals may be 6 or 6.5. In up to 50 years, it may be 6.5 to 70. After 60 or 70 years, it may be 7.5 or up to 8 also, if the person is aged about 75 or 80 years. Because if you keep the HbA1c at a very, very lower level in the elderly individuals, you are inviting hypoglycemia, and definitely hypoglycemia will increase more and more cardiovascular risk. But 90% of our Indians, they are not reaching their target because of the several reasons, and one reason is poor knowledge among our doctors or poor awareness among the public. And if you see here, the HbA1c or the fasting blood sugar, postponed blood sugar, 70% they are not reaching it. So what will happen when the patient is having the diabetes and also the comorbidities with associated risk and the complications? Unfortunately, 60% of our diabetics are obese, whereas Western population, almost 90% of the obese are overweight, type 2 diabetes. Whereas in India, we have the overweight type 2 diabetes, we have obese type 2 diabetes, we have the normal weight type 2 diabetes also. And as I told you that nearly 70% are the hypertensive, so we should not underestimate the value of the BP reduction in all the diabetic individuals. There is about 2 to 4 fold increase in the risk of the complications, and about 40 to 70% increased risk of the renal failure in all the diabetic individuals. So what are the limitations of the currently available therapies? Even though we have a lot of the drugs, I say nearly 200 different drug combinations are there for the management of the diabetes. See hypoglycemic episodes, even you are using the sulfurias or the insulins, so obviously hypoglycemia will occur. So that one should be very careful about it. And when you are using the metformin and the GLP-1 receptor agonists, they will be having the gastrointestinal side effects like nausea, vomiting, cramps or the loose motions, etc. And poor responder rates, so all the people, they will not respond the same. In 2023, the fellow responded very well to 1 or 2 tablets, but that is not right in today's, because even after 3 or 4 tablets, here still the blood sugars are very high. So it should see that the blood sugars should be responded every year. And you also see that weight gain is very, very common in the diabetic management. So if you are using the sulfonylureas or the insulin, and some people will have the edema, especially the pioglitazone, and also the risk of the heart failure with the pioglitazone and also with the saxagliptin. So what are the challenges in the type 2 diabetes management? We are dealing a case of diabetes means it's a progressive and it is a dynamic and it is an aggressive. It's a very, very complicated disease in some individuals. So that is the reason your treatment also very progressive and aggressive. Monotherapy insufficiency is very common in all of our diabetic individuals. Maybe 10% of our diabetes, they will be controlled under simple metformin or some other drug, but 90% they need a combination therapy. And most of these people should have a complement reaction. One should not use 2 sulfonylureas or 2 begonides or 2 gliptins in a single person. So you choose these drugs in a different ways so that you can complement each other, and finally you can attack that ominous octet of your hyperglycemia. And there is a lot of cost of the delayed intensification. This is the slide from the UK. They have studied near the 1 lakh diabetic patients. So between 1990 and 2012. So they say that if you delay 1 year delay in receiving the intensive treatment in patients with the HbA1c more than 7%, there is a risk of 67% of myocardial infarction. So what is the average HbA1c of our Indian population? 9.3 or 9.8. So beyond 9 is our average HbA1c. If you see just if it is more than the 7 in 1 year delay in your intensive management, so there is a lot of risk of getting the myocardial infarction by 67%, heart failure by 64%, and stroke by the 51%. So it clearly shows that there should not be a delay in our intensification of our medication. So there should always be a combination, and if situation demands, you have to go for 3 drugs, 3 OHs or 4 OH or the basal insulin or basal bolus, etc. But ultimately, you have to keep your HbA1c around 6.5 and fasting blood sugar around 100, postprandial around 140. So these are the armamentarium of the anti-diabetic drugs. You have the insulin sensitizers, like your begonides is the metformin, thiazolidine is the pioglitazone. So they attack your insulin resistance, they act as insulin sensitizers to keep or to move the glucose from the circulation to the muscle or the liver or the adipose tissue. You have the insulin secretagogues like the sulfonylureas. You have the 4 sulfonylureas in our area, and also we have the repaglinide, that is also very useful. A short-acting sulfonylurea which controls your postprandial hyperglycemia. Usually you combine the repaglinide with the oglibose. And we have the incretin-based therapies with the GLP-1 receptors. So last Saturday we had a discussion with the GLP-1 receptor, your injectable semaglutide, Wegovy. And the gliptins, you are all familiar with your teneligliptin, sitagliptin, lenagliptin, etc. And alpha glucose inhibitors are also very common in our people because we take lot of the rice. They cause postprandial hyperglycemia. So it acts as a absorber, gastric carbohydrate absorption inhibitor, that is our oglibose. SGLT2 inhibitors are the favorite drugs for all the diabetics and high risk individuals. Even the non-diabetics also, now the SGLT2 inhibitors are very useful in heart failure and CKD. And coming to the insulin therapy, how the basal insulins can be used as a nighttime dose to reduce your fasting hyperglycemia, and then the prandial insulins to reduce your postprandial hyperglycemia. And they will come for all the type 2 diabetics after 30 or 40 years of the life. They almost behave like the type 1 diabetes, where you have to go for the basal bolus, maybe 3 shots of your regular and 1 shot of your basal insulin. So these are the different drugs. Begonide is a metformin. Where it acts at the level of the liver. They decrease the glucose production in the liver, improves the insulin sensitivity. And sulfonylureas, they act on the pancreas. They stimulate the beta cells to release more and more insulin. DPP4 inhibitors, they increase the insulin secretion, decrease the glucagon secretion. They act on both alpha and the beta cells. GLP-1 receptor agonists, they are also act like the alpha cells and also beta cells. They also act on the brain to reduce our appetite. So SGLT2 inhibitors, they totally act on the kidneys to block the reabsorption. Thiazolidine, they act as insulin sensitizers at the level of the muscle, adipose tissue, and the liver. Miglitinides, they act exclusively on the postprandial hyperglycemia. Alpha glucose inhibitors, they act exclusively on the intestines. And then the insulin is the very, very important drug, thanks to Banting and the best for their greatest discovery of the insulin. What about the understanding of the SGLT2 inhibitors and the DPP4 inhibitors? They are the different major landmarks as per the DAFA is concerned. So they declare TIMI So that shows you a cardiovascular, the people involved here are the people of atherosclerotic cardiovascular risk and the multiple risk factors, and DAPA heart failure. So the people with the heart failure, especially the REF, reduced ejection fraction people will be involved here. DAPA CKD, so all the CKD population, CKD means doesn't mean that elevated creatinine, even the proteinuria is also the CKD. So the deliver means here the ejection fraction more than the 40, less than the 40 is the DAPA HF study, and more than the 40 is the deliver study. In here, both the preserved ejection fraction as well as the mildly reduced ejection fraction. These are all the different trials undertaken with the dapagliflozin. So in the declared TIMI, that is one of the largest study, nearly 17,000 people are studied here. All the people are at the risk of getting the atherosclerotic cardiovascular disease or the multiple risk factors. All are type 2 diabetic individuals in the declared TIMI, whereas in a DAPA HF and the CKD, even the without the diabetes, even the normal non-diabetics are also included in these studies. That is the reason though the dapagliflozin or empagliflozin are used even in the non-diabetics also. Here the mean GFR in the declared TIMI is very good kidney function, it's more than the 85. Their creatinine level is always 1 or 1.1 only. Whereas in the heart failure in the DAPA CKD trials, the GFR is less than 66 or at the 43. That means the creatinine level may be 2.5 or 3, etc. And primary endpoint in the declared TIMI is the CV deaths, whereas the heart failure, again the CV. In the CKD, in the primary outcome is your renal outcomes. Whereas secondary endpoints for the declare and the DAPA HF is the renal outcomes, whereas for the DAPA CKD, the secondary endpoint will be the cardiac effects. So this is the declared TIMI in all the atherosclerotic or multiple risk factors. They say that this is the largest SGLT2 inhibitor trial, which included a broad representation of the first degree and the second degree prevention programs. Dapagliflozin reduces the cardiovascular disease and also hospitalization for the heart failure. So that is very, very important. Safe with regard to the MACE and appear to reduce the renal events regardless of the baseline atherosclerotic cardiovascular disease or the heart failure. In the primary and secondary outcomes in the DAPA, among the patients with the CKD, regardless of the presence or absence of the diabetes, whether the diabetic or non-diabetic, the risk of a composite of a sustained decline in the estimated GFR of at least 50%, end-stage kidney disease, that is your ESRD, posted for your dialysis or transplantation, or death from the renal or cardiovascular disease was significantly lower with the dapagliflozin than the placebo. Deliver study, already I told you, here the ejection fraction more than the 40 they included in the mildly reduced or the preserved ejection fraction. There also you will have a good effects. So secondary results, delivery study, that also showed very good results. So this conclusion is also very good. So constants of the benefits exceed the range of the ejection fraction. So at the end of the story, the dapagliflozin can be used with the E of more than 50 or 40 to 50, even the less than the 40. So that means when the fellow is at risk of the atherosclerotic cardiovascular, the heart failure, dapagliflozin must be included in most of our people, irrespective of your heart failure, irrespective of your ejection fraction. So no difference in the benefit over the ejection fraction. You got very good benefit for the outcome of all causes of the death, CV death, heart failure, hospitalization, MI, stroke, compared to the placebo. So wide scope of the dapagliflozin in the clinical uses. When the fellow is type 2 diabetes and very high risk factors like type 2 diabetes, obesity, hypertension, smoking, good, you can use dapagliflozin. Type 2 diabetes plus CVD, already had LVH, already had angina or unstable angina or past history of the myocardial infarction or intermittent claudication or history of TAA or history of the CVA. So you can have to use the dapagliflozin. Diabetes with CKD, with the proteinuria more than the 3 weeks, 3 months, or your elevated creatinine levels, you can use it. Heart failure, irrespective of your ejection fraction. Even now, the last 2 points are very important. Non-diabetic with heart failure, non-diabetic with CKD. So when you are having advantages in the non-diabetics, why don't you use the advantage of this drug in a diabetic individual? What about the cardiovascular and the renal benefits of the sitagliptin? We discussed something about the DAPA. Now we'll move on to the sitagliptin because this combination. So sita is nothing but the DPP4 inhibitor. So it's an incretin drug. Last time also I discussed about you when you are taking the oral food that gives signals to your intestines, and intestines will start releasing your SGLT2i receptor agonist. That is very good, but unfortunately that will stay for only 5 to 10 minutes and will be destroyed by this DPP4 enzyme. So now that is DPP4 enzyme is the villain. Now we have the drugs to inhibit that enzyme, the villain, so that your endogenous GLP-1 will be stay in the longer period. So it have incretin effects and also the direct effects. It is glucose dependent. So when you have the hyperglycemia, these drugs will act. When there is no normoglycemia, they won't cause any hypoglycemic effect, unlike your sulfurias. These drugs will increase your insulin secretion. I told you that they also act on the alpha cells, so they reduce the glucagon, which is as a benefit effect, because glucagon hyperglucagonemia obviously increase hepatic glucose output, again more and more hyperglycemia. So sitagliptin monotherapy in Asians, it works wonder in Asian individuals. So improved the 2-hour postprandial insulin, 2-hour postprandial C-peptide. So C-peptide means your endogenous insulin production is good. Insulinogenic index and the deposition of the index together with the improvement of HOMA beta and reductions in the HOMA IR. That means reductions in your insulin resistance and improving in your insulin production. TCAS is the very important study with the sitagliptin, effect of the sitagliptin on the cardiovascular outcomes in the type 2 diabetes. So here the patients aged more than the 50 years with the type 2 diabetes, and their HbA1c is somewhere between 6.5 to 8%, receiving the stable oral glucose lowering therapies and or the insulin in some individuals, and pre-existing vascular disease. So those people with atherosclerotic cardiovascular disease, high risk individuals aged more than the 50 years, somewhere between HbA1c 6.58 were included in this study. The nearly the 14,000 population, and sitagliptin was given 100 milligrams daily, and their primary endpoint was CV related deaths or unstable angina requiring hospitalization or non-fatal strokes or MI. So these are all the baseline characteristics. Here the beauty of this study is 22% of the Asians. See, unfortunately, some of the studies, when we see the international studies, no one is from the Asia, no one is from the India. So that may not be applicable for the Indian population. Whereas these studies, recent studies, they know the importance of the Indian as far as the diabetes population is concerned. So they also included our Asians or the Indians in there. Here there is about 20% of this population are the Asians. So in conclusion, sitagliptin was non-inferior to the placebo on the primary MACE effects. No significant difference in the rate of hospitalization for the heart. Major safety concerns in the large clinical trials evaluating the DPP4 inhibitors. Thanks, Emma. So the heart failure, pancreatitis and pancreatic cancer. See, if you see the gliptins, the one gliptin which is not useful or at the risk of getting the heart failure is the saxagliptin. That is the reason saxagliptin was not useful or is not contraindicated in use in the edema people or that risk of getting the heart failure. But recent studies say that saxagliptin can be safely used in the heart failure, but first impression is the best impression. So that is the reason now the saxagliptin we are not at all using it. So we are using either sitagliptin or the linagliptin as the gliptins of the choice for our population. And as you all know that the common side effect here for the gliptins is the respiratory tract infections or pancreatitis. So a chronic alcoholics who are at risk of getting the pancreatitis or already the past history of the pancreatitis, better not to use the gliptins. So in summary of the sitagliptin story, the TCAS trial shows sitagliptin was non-inferior to the placebo, highly selective versus the veldagliptin, the saxagliptin, renal impaired with dose titration and in mild hepatic impaired patients. So you have to respect the kidneys as far as the gliptins usage is concerned. And one gliptin where you can be safely used irrespective of your creatinine levels is the linagliptin. That doesn't mean that all the other gliptins are contraindicated in the renal failure. You can use any gliptin of your choice in the renal failure, but you have to reduce the dosages according to your GFR if you want to use other than the linagliptins in the CKD. So the same happens to the sitagliptin also. That is the reason sitagliptin is available in the doses of 25 mg, 50 mg, 100 mg. Even though our dose is 100 mg, in the CKD population you can reduce to 50 and the 25 according to your GFR. So these are the pharmacokinetics and the dynamics. Here the DPP4 selectivity more than 2600 with the sitagliptin, more than 10,000 with the linagliptin. Oral availability nearly 87% the sitagliptin, and kidney excretion is about 87%. That is the reason we have to respect the kidney function when you are using the sitagliptin. Whereas you see the linagliptin, the kidney excretion is just 5%. So that is the reason you can safely use it in the renal failure without the dose alterations with the linagliptin. So here the SGLT2i inhibitors, again the bioavailability is very good, half-life is 13 hours. So this combination, the DAPA and the SETA, why this combination is the best means half-life is same and also the dosing is also the same. Suppose if you want to use the veldagliptin, you have to use the BD, whereas the sitagliptin is OD dosages. I told you that there is a need for the combination therapy in most of our diabetic individuals because of your enhanced glucose control, synergetic effects, and you have to reduce the A1C reductions, and the cardiovascular and the renal benefits, weight management, simplify the treatment regimen, and should be personalized approach. This is a good study, efficacy and safety of this combination therapy of SGLT inhibitors and DPP4 inhibitors in the treatment of the type 2 diabetes. They say that this is the complementary mechanism of the actions. When you are using the SGLT inhibitors, they act on the kidneys. There is a main action, you know that, glucosuria, and then the reduces the glucose toxicity, reduces the weight, reduces the systolic blood pressure because natriuresis, glucosuria, and also tubuloglomerular feedback. So all these things are discussed in the last class. And DPP4 inhibitors, they act on the pancreas and also on the intestines to reduce your gastric motility. So finally, so both this combination will reduce your hyperglycemia and also have the pleiotropic effects because it reduces the blood pressure, body weight, etc., weight neutrality. This combination is a complementary, treat early and treat right. So treat early in all the diabetic individuals, treat the right combination. So I think this is the one of the best combinations is the gliptin plus the SGLT inhibitors. So who are that good people, subset of the population where you can use this combination? So high cardiovascular risk. So definitely you need the cardioprotective drugs like your SGLT inhibitors and the gliptin. All the kidney disease population. So because of these positive effects of these SGLT inhibitors and the gliptins, you can safely use. All the obese individuals, you have a added advantage, pleiotropic effects in reducing the body weight also with the SGLT inhibitors. And inadequate glycemic control, that is the most important indication for most of our Indians because our HbA1c is beyond 9. So you need a combination of the drugs. So this combination will address all these things. So if you see these 4 groups, I think most of our diabetes will come under 90 to 95%, they comes under this group. So some are at high risk cardiovascular risk, use this combination. Some are at the CKD, use this combination. And 50% of ours are obese. So our BMI is less than 23 is the normal. And our waist circumference is less than 90 in the males and less than 80 is the females. So more than that, we are all obese. So definitely we have the choice of using this combination. And most important is most of our people are at inadequate glycemic control. So definitely there is always a role for this combination. So sitagliptin increase the GLP-1, improving the glucose-induced insulin secretion, maintenance of the beta cell, decrease the blood glucose, and proven CV safety. And dapagliflozin is fortunately is one of the important drugs to be used, shown cardiorenal benefits in all the trials. So the fixed dose combination is very good. So these are all the rationales. Clinical approach to the combination is in the Indian diabetes setting in our population. This combination is OXRA-S, so the dapagliflozin and the sitagliptin. Consideration for this combination as the first line therapy in about 88%. Common background therapy when the people with the metformin therapy or metformin with the AGA or metformin with the dapagliflozin, sitagliptin, all these combinations you can use this. There is a fixed dose combination, so compliance will be good. The price reduction is also will be there. Hypoglycemia risk is very low with this combination unless you combine with the sulfonylureas or the insulin. This because of the multiple comorbidities and patient compliance and the high HbA1c at the target, the diagnosis itself. So there is always a role to use this OXRA-S. Expert opinion. This is the optimum clinical approach to combining is a pan-India study. Manoj Chadda from Delhi, Ashok Kumar Das from Pondicherry, Vishwanath Mohan is from Chennai, Anup Mishra from Delhi, Jyotidav Kesavdas from Trivandrum. So pan-India study. So finally they say that decision making based on the glycemic factors, glycemic control, CV risk, CKD risk, and weight loss or preventing hypoglycemia, you can use this combination. So this is suitable for our Indian patients, efficacy and safety wise, beta cell function, extra glycemic benefits, the pleiotropic effects, etc. Overall compliance, obviously once there is combination, so definitely the people, the compliance will be definitely good. So this is the perfect combination because of the evidence based, Indian patients, patient centric, and beyond the diabetes. So patient input, healthcare system impact, and community impact all useful. So conclusions, glycemic control will be good, cardiovascular benefits will be there, weight reduction will be there. Thank you very much for your patient hearing.